Hey, good day. Our discussion will be all about gestational trophoblastic neoplasia. I am Dr. Maria Shiriel Armero, and this will be Gynecology Module 3. So from the objectives given to us, the student should be able to, number one, describe the symptoms and physical examination findings of a patient with gestational trophoblastic neoplasia, including molar pregnancy. So the first few slides will talk about molar pregnancy. And apart from molar pregnancy, we should be able to describe the types or classifications of other gestational trophoblastic diseases and their manifestation and pathology. And of course, we should be able to, third, describe the diagnostic methods, treatment options, and follow-up, and recognize the difference between the gestational trophoblastic diseases, specifically molar pregnancy and gestational trophoblastic neoplasia. Let me ask you this question first. What is the serum marker of pregnancy? So I hope you were able to answer correctly during your examination. The answer is beta HCG. Again, the question is serum marker for pregnancy. Human chorionic gonadotropin is the hormone released by the syncytial trophoblast. However, the alpha subunit is similar with other hormones such as luteinizing hormone, follicle stimulating hormone, thyroid stimulating hormone. And so therefore, to be specific to the serum marker of pregnancy, it should be beta HCG. Gestational trophoblastic diseases, for us to be able to become successful in managing this, we should remember the three. R, C, S. R, we should be able to recognize the disease. Diagnosis is very important. Once the disease is being diagnosed, the next will be C, effective chemotherapy. And the S is we should be able to determine the status of the disease with surveillance through, as I have mentioned, the beta HCG assay. So there are several histologic categories. They are divided into three. According to the book, there is the benign trophoblastic lesions. There is the H mole or the Hydatid mole. And the third is the gestational trophoblastic neoplasia or the malignancies. I will be emphasizing the difference of complete and partial mole in the succeeding slides, as well as the difference between the molar pregnancy and the gestational trophoblastic neoplasias. So this is the illustration of the pathologies I have mentioned. Now, as you can see in the picture, the molar pregnancies, the difference between the two is that the partial H mole has a fetus or has fetal tissues inside apart from the presence of the abnormal growth of the placenta. While in the lower portion, he will be able to appreciate the gestational trophoblastic neoplasia, the invasive mole. These are chorionic villi and trophoblasts that invades beyond the endometrium. So we call it the invasive mole. While the most common or the dominant histologic pattern is the choreocarcinoma, which compose only of the cytotrophoblast and the syncytial trophoblast. It does not have the chorionic villi on histology. And the last two are the placental cytotrophoblastic tumor and the epithelioid trophoblastic tumor, which is a variant of the PSTT. So we go first with H mole or the Hydatid mole. It is an abnormal conception with excessive placental growth with or without fetal development. It's around 1 to 3 per 1,000 pregnancies in the world. And in the Philippines, around 2.4 to 14 per 1,000 pregnancies. Risk factors include age, so extreme of ages, less than 15, more than 35. OB history or prior H mole. When you ask the patient, she had already a history of gestational trophoblastic disease, diet and nutrition, low intake or yes, a deficiency in beta carotene and animal fat, and genetics. There's what we call the familial gestational trophoblastic disease. No, those can be the risk factors that may be present in a patient. Again, H mole can either be complete or partial. So in this illustration, you'll be able to appreciate how come the karyotype, there's a difference in the karyotype for complete and partial. Now, normally, there should be two sets of genes, one paternal and one maternal. I hope you can see my pointer. Okay, let me use this. Okay, one paternal and one maternal. Now, as fertilization occurs, so results to a normal fetus. While in a complete mole, there is absence of the maternal gene. So as you can see, only the paternal remain, and duplication occurs, resulting to still a 46 chromosome because there will become two sets of paternal genes due to duplication. And for the partial mole, it becomes a triploid because there are three sets of genes, two paternal, bipaternal, and one maternal. So it becomes 46. Not anymore 46, but 69. Okay, there are two variations in complete H mole. It can be either monospermic or dispermic. So it can be an XX or it can be an XY, depending on how this is formed. Again, it's universal that there is loss of maternal chromosome before or after fertilization, and there is either a duplication of the paternal chromosome, only one sperm and then duplicated, or it can be dispermic. So there are two sperm gene source. Okay, to differentiate complete versus partial mole, number one, of course, very important, from the presence of embryonic tissues. For partial mole, you should remember that fetal or embryonic tissues are present. Swelling of chorionic villi should be diffuse in complete moles. Hyperplasia of the trophoblast also diffuse in complete moles in comparison to partial moles. Stromal inclusions in the trophoblasts are present in partial mole. And as I mentioned earlier, partial moles are bipaternal. There are two sperm, no? There are two sperm and one maternal gene. Karyotype, complete mole is still a diploid, while the partial mole is a triploid. Here, the last featured, the persistent human chorionic gonadotropin, usually occurs among complete moles, but very rarely among partial moles. So what are the signs and symptoms? Usually it's first trimester bleeding with or without molar vesicles, enlarged for Dates uterus. These are the two that are very commonly seen as signs and symptoms of patients who come in with molar pregnancy. Now, apart from large for Dates uterus, even when the uterus is large, but the patient fails to appreciate fetal movement. And because of the bleeding, there can be an occult blood loss, hypertension before 20 weeks can be observed. And because of the excess HCG, there is stimulation of the ovaries producing theca lutein cysts. There is excessive vomiting, hyperemesis gravidarum, hyperthyroidism. Again, as I mentioned, there is cross-reactivity of HCG to 3 other hormones, including TSH, and respiratory distress due to trophoblastic emboli. And among these signs and symptoms, I also highlighted hypertension before 20 weeks, theca lutein cyst, and hyperthyroidism as rare signs and symptoms in partial molar pregnancy. To be able to help us diagnose molar pregnancy, we should remember that simple ultrasound is a standard imaging modality. What do we see in the ultrasound? There is the snowstorm appearance, especially in the second trimester scan in complete H mole. There is an echogenic endometrial mass with a large uterus in that ultrasound. While specifically, if we are looking at a possible partial H mole, there is a presence of embryo apart from the placental findings. If there is no embryo yet, we also find an increased gestational sac diameter that raises our suspicion of partial H mole. In second trimester scans, we'll be able to appreciate amniotic fluid in partial H mole. The echoes in chorionic villi is present in both, while theca lutein cysts are present in complete H mole. Histology increases diagnostic accuracy. So what does this mean? If there are meaty tissues or vesicles that come out, it will be prudent to have this sent for biopsy for us to, again, increase diagnostic accuracy. And for the beta HCG determination, complete H mole usually presents with very high beta HCG. Now, the beta HCG measurement in normal pregnancy usually plateaus at 10 weeks age of gestation and falls thereafter. And so a persistently high beta HCG raises this suspicion. Again, I asked this in the exam. I hope you were able to answer this. What hormones that are released from the anterior pituitary contain similar alpha subunit with HCG? Please do not forget this. Luteinizing hormone, follicle stimulating hormone, thyroid stimulating hormone. Again, these are the 3 hormones with similar alpha subunit with human chorionic gonadotropin. So again, if you can see here, the HCG, FSH, TSH, and LH has the same form of the alpha subunit. They differ on their beta subunits. Again, success is through RCS, recognition, chemo, and surveillance or status of disease with beta HCG assay. Now that we are able to recognize the disease through its signs and symptoms and diagnosis, it allows us for an optimal treatment plan. Therefore, apart from the ultrasound, we should also request for other laboratories, just X-ray, for us to be able to identify if there are no metastases, more especially in the lungs because it's the most common site. CBC, because as we said, there is an occult bleeding, so we should be able to identify how bad the bleeding is. Blood typing with RH, liver function tests also. Since excretion of possible chemotherapeutic agents also will occur in the kidneys, so we'll also request for kidney function test. If you are highly suspicious of hyperthyroidism, of course, part of it also is you request for thyroid function. So there you go. But at least, again, do chest X-ray. Now, treatment, there are 3 modalities. We're talking about molar pregnancy, okay? Let's focus our mind on molar pregnancy first. Now, the treatment is suction, dilatation, and curettage. This is the preferred method, especially among reproductive age women willing to preserve their uterus. Now, because of the large for gestational age uterus, the distension brought about by the vesicular tissues, we should also infuse oxytocin to cause uterine contractions. The second mode of treatment can be hysterectomy. This is more commonly offered among patients who are already able to achieve their family size, or fertility is not anymore an issue. What's the benefit of hysterectomy? It eliminates the risk for local, or we call it myometrial persistence. However, it still does not rule out the possibility of distant metastasis. Remember, the molar pregnancy should be just within the endometrium. Now, if it involves the myometrium, then it's still considered a there is a local invasion. No? So with hysterectomy, we eliminate that risk, no, of local persistence or invasion. And also, especially among women of 40 years old and above, whereby there is a higher risk for post-molar gestational trophoblastic neoplasia, hysterectomy decreases this risk, and further the risk of chemotherapeutic treatment. Now, the third can be also the prophylactic chemotherapy. Especially, this is offered among or given among patients who has limited access to follow-up. No? If by your assessment, you know that there is a likely risk that this patient will fail to follow up. These patients are high risk to develop further gestational trophoblastic neoplasia. And the chemotherapeutic agents that we use are single agents, actinomycin D or methotrexate after surgery. So who are then the patients who are high risk to develop GTN or gestational trophoblastic neoplasia from a molar pregnancy? Number 1, again, the age is very important. You remember the age, 40 years old. Baseline beta HCG, more than 100,000. Prior history of gestational trophoblastic neoplasia, you look at the OB history, hyperthyroidism present, trophoblastic emboli, large for gestational age uterus, and fecal lutein cyst more than 6 cm. So if you see these characteristics present in your case or in your patient, then prophylactic chemotherapy should be given. Again, A, age, B, baseline beta HCG, 2, H, history of GTN, hyperthyroidism, then TLT, trophoblastic emboli, large for gestational age, and fecal lutein cyst. Again, the measurement should be more than 6 cm. So that will give us a higher risk to develop GTN. Again, fecal lutein cysts are present in complete H-mole. All right. Surveillance, what do we do? So we get beta HCG, of course, at day 0 prior to suction DNC. Then 48 hours immediately from evacuation. Then weekly until the results become negative. Usually the span, the days usually is 56 days. So better prognosis if there is normalization before 56 days. And then once there is a normal result, we should do a weekly beta HCG, 3 weekly beta HCG measurement. Normal values, again, less than 5 international unit per ml. So if there are 3 normal weekly values, so again, 721, day 0, 48, 7, 721. So if we see that there is, if we see that there is a normal value of the HCG post-evacuation for 3 consecutive weeks, for 3 weekly beta HCG determination, then we'll do a monthly beta HCG monitoring for 6 months. So basically, it should be the monitoring, the surveillance is around less than a year, because once the results, the weekly results become normal, then we go for monthly for the next 6 months. And then we can already plan out, especially if the patient wishes to get pregnant again. However, during this surveillance, it should be emphasized that there should be an effective contraception, because we do not want the presence of a physiologic HCG because of a normal pregnancy, giving us a confusion whether there is recurrence or progression to GTN in our patient. So IUD is contraindicated because the uterus is large, perforation can occur. And so oral contraceptive pills is the most ideal, because as HCG cross-reacts with the luteinizing hormone, then the oral contraceptive pill does this action of inhibiting the action of the LH. And so again, apart from contraception, it counteracts the action of the luteinizing hormone. There is also what we call the phantom beta HCG. So there are 3 other dilemma that you'll be facing during the surveillance. There are people with phantom beta HCG. There is a persistently low level of beta HCG. Secondary to heterophilic antibodies. So these are the ones that are exposed to farm animals. And because the heterophilic antibodies are large glycoproteins, they fail to be excreted in the urine. And so when we do a urine beta HCG, it's negative. Okay. So that's phantom beta HCG. How about quiescent GTD? They usually consider this pre-malignant. However, there is absent clinical or radiologic evidence, but beta HCG is maybe up to 212 international unit per ml. There is also a pituitary beta HCG. This is the beta HCG released in the pituitary, which naturally occurs among perimenopausal or postmenopausal women. So those, again, those are the molar pregnancies, complete and partial mole. So as we move on to the trophoblastic neoplasia, let me just emphasize and summarize what we have learned so far in in the molar pregnancy. So we have a case here, TY, 35 years old, with her last menstrual period of November 28th. She's a fruit vendor from Mantalongon, so it's quite far from Cebu City. 1 week prior, she was seen at the hospital due to a positive pregnancy test and had been vomiting. Temporarily relieved by rest, she was advised to do an ultrasound and serum beta HCG level and further referred to Southwestern University Medical Center. She has her past medical history is non-contributory. Her family history is hypertension on the father's side. She had 2 other pregnancies before this current, 2011 for a normal vaginal delivery, and 2017 complete miscarriage. She's been married for 8 years and wanted to have another pregnancy. On the vital signs, we note elevated blood pressure, elevated blood pressure of 140/90, tachycardic, and increased RR at 24 cycles per minute, not febrile. Okay, so abdomen is non-tender and no fetal heart tone or appreciated. On bimanual pelvic exam, the uterus is noted to be enlarged at around 12 weeks size, and there is a bloody mucoid discharge, non-foul smelling. The TVS noted a complex echogenic intrauterine mass with cystic spaces. No embryo noted, and there is a bilateral thecal lutein. There are bilateral thecal lutein cysts measuring 6 cms on the right and 7 cms on the left, while the beta HCG level is 112,000 international units per liter. Very straightforward case, so I hope you'll be able to identify the very glaring details, no, in this case, so which are highlighted or are now bold. So you should be able to at least have a complete diagnosis of the case. You should know what laboratories you should request, treatment modality, and further management for us to be able to at least achieve the objectives we have mentioned at the start of this lecture. So for the complete diagnosis, do not forget the OB score. Since this is her 3rd pregnancy, she's a gravida 3. Only one pregnancy went beyond 20 weeks, para 11011, because of one miscarriage. We are considering that this is a complete Hydatid mole because number 1 of the cystic spaces present in the ultrasound, but there are no fetal tissues noted. Also included in the diagnosis is the ovarian new growth bilateral. These are thecal lutein cysts by ultrasound. Likely these, so we can just say ovarian new growth bilateral, probably benign, considering thecal lutein cyst, bilateral thecal lutein cyst. Again, laboratories that you should request, very important, is just X-ray to identify if there are any lung metastasis or emboli that can occur, CBC for occult bleeding, blood typing for possible blood transfusion, liver function because of the possibility of giving chemotherapeutic agents, BUN creatinine, also renal function test because the excretion of the chemotherapeutic drugs are through the kidney, thyroid hormones determination, because again, the cross-reactivity of HCG with TSH, urinalysis, and ECG. Those can be the laboratories that you can request. Again, treatment modality, there are 3 options: suction curettage, hysterectomy, and chemoprophylaxis. For this case, we'll not choose hysterectomy. Why? Number 1, she is young and still desirous of pregnancy. And so suction curettage will be the best treatment modality that we shall choose for this patient. Also, because apart from there is a risk for a low follow-up because she is from the far side of Cebu province, we look at the levels of the beta HCG, which is more than 100,000. There are bilateral thecal lutein cysts more than 6 cms, and so it is advised to add chemoprophylaxis. What do we do with the ovarian new growth? Should we do cystectomy? No, we just have to leave it behind because it will undergo spontaneous resolution once the condition is also resolved. Further management of the patient after treatment, so surveillance, serial beta HCG monitoring weekly until normal, average 56 days, then monthly for the next 6 months. Again, combined oral contraceptive for contraception. She can now, again, this is individualized because this is a case of TY, 35 years old, only one successful pregnancy, married for 8 years, but no child yet with the current partner. And so we should encourage that we will achieve pregnancy after 6 months once the condition is cleared as early as 6 months. And then once she gets pregnant, an early ultrasound should be advised to be able to detect early if there is recurrence of the molar pregnancy. And after Delivery, a beta HCG 6 weeks postpartum should be requested to identify occult progression to gestational trophoblastic neoplasia, which occurs most commonly after any pregnancy. And of course, we should send the placenta for biopsy once she delivered already the next successful pregnancy. In the book, 7th edition, there are, what's this? 4 criterion for the diagnosis of gestational trophoblastic neoplasia. However, not 4, 5. However, in the 8th edition, we'll consider 4 beta HCG values that plateaued. Again, how do we remember? Plateau for 4 beta HCG values that plateau over a 3-week period. So 1, 7, 14, 21. Now, that's plateau. What if there is an increasing value or a rising value of 10% or greater? So it should be measured over a 2-week period. Okay, 3 values in a 2-week period, 1, 7, 14. And of course, we send this for biopsy. There is diagnosis of choriocarcinoma, so that will already give us not anymore a molar pregnancy, but a gestational trophoblastic malignancy or neoplasia. And of course, presence of metastasis. Metastasis, whether beyond, as long as it's beyond the endometrium, it's already called invasion. Okay, myometrium, lungs, and other parts. So again, to recall, these are the molar pregnancies. Okay, these are all gestational trophoblastic diseases, and these are the molar pregnancies, while these are the neoplasia or the malignancies: invasive mole, choriocarcinoma, PSTT, or ETT. So again, we have to recall, so you will understand what I'm trying to say here. This is the endometrium. Again, for gestational trophoblastic diseases occurring only in the endometrium, molar pregnancy, either complete or partial. Now, in the myometrium, if there is invasion already in the myometrium, instead of calling it molar pregnancy, we call it invasive mole because it has gone beyond the endometrium. And lastly, beyond the uterus, no? So the third layer is serosa, the serosa or the visceral peritoneum. Those are the 3 layers of the uterus. Now, we talk first about invasive mole. So as you can see, we compare these are the molar pregnancies. As you can see, there is no interruption. It stays within the endometrial cavity, while the invasive mole, as you can see, has invaded the myometrium. So villi extended to the myometrium. So histologically, what do we see? The site of trophoblast, in situ site of trophoblast, and the chorionic villi. And it just happened that it extended into the myometrium, and so the diagnosis is an invasive mole. Again, locally invasive because it went beyond endometrium. The most common reported symptom of invasive mole is that there is persistent vaginal bleeding after a pregnancy. There is a uterine perforation with intraperitoneal hemorrhage and infection secondary to tumor necrosis that can occur in invasive mole. How about gestational choriocarcinoma? We have to specify that this is a gestational choriocarcinoma because we also have a non-gestational choriocarcinoma that can arise in the ovaries. No? So gestational choriocarcinoma is a dominant histology for metastatic gestational trophoblastic neoplasia. There's 1 in 50,000 pregnancies, and there are sheets of anaplastic trophoblastic tissue containing cytotrophoblast and syncytial trophoblast without chorionic villi. In comparison to invasive mole, apart from the trophoblast, there is presence of chorionic villi, but with gestational choriocarcinoma, there is no chorionic villi. Well, there is a very fast spread because there is a vascular or a hematogenous route in gestational choriocarcinoma. Again, as I mentioned, there is what we call the non-gestational choriocarcinoma in the ovary, which is highly aggressive, that develop without pregnancy, and like gestational choriocarcinoma, also secretes beta HCG as a serum marker. And the difference, most especially, is that there is an absent paternal DNA in the gonadal or in the ovarian choriocarcinoma. While in gestational choriocarcinoma, we understand again that it started as a molar pregnancy that progressed to gestational trophoblastic neoplasia, specifically gestational choriocarcinoma. How about the PSTT and ETT? So in the histology, what we see instead of cytotrophoblast and syncytial trophoblast, we see our intermediate trophoblasts. So these are less prone, unlike choriocarcinoma, it's less prone to hemorrhage, invasion, and necrosis. However, these are most commonly associated with metastasis at the time of diagnosis. And unfortunately, it's relatively chemo-resistant. So how do we diagnose? There are tests for us to give us diagnosis of PSTT and ETT. And what is specific here is that it's not HCG, unlike the other GTNs. Okay. Sites of metastasis of gestational trophoblastic neoplasia, since these are highly vascularized and with thin wall fragile vessels, again, hematogenous route, it can be local in the vagina and can be distant in the lungs. It's the first organ involved, and all the other organs. So for us to remember the staging, you have to remember that extension to the lungs is not yet stage 4. It's stage 3. Okay. So again, it's stage 1 only if it's confined to the uterus. If it's beyond the uterus but limited to the genital structure, it's still stage 2. But if on chest X-ray, there is extension to the lungs, then it's 3, and all other metastatic sites 4. So the FIGO prognostic scoring for GTN is scored as either 0, 1, 2, 4. There is no score of 3, okay? Depending on the characteristics, we add the characteristics present in our case, okay? Now, remember that there is a cutoff score of more than or equal to 70. If there is more than or equal to, if the score is more than or equal to 70, then it's considered high risk. So if it's high risk, then instead of a single agent, we give multiple agent, okay? So again, remember 7 for high risk. Letter H, A, B, C, D, E, F, G, H, 7. Okay, that's how I remember it. All right, age, antecedent pregnancy, OB score, HCG, the size of the tumor, metastasis, the number of metastasis, and chemotherapy that have failed. So again, of course, very important is the ultrasound with Doppler. There is hypervascularity and areas of tumor necrosis. CT scan will help us identify the interface between the normal myometrium and the trophoblastic tissue, while chest X-ray is the test of choice to rule out lung metastasis. If you are asked what test is the choice for us to be able to identify if a patient is in stage 3, then just X-ray will already help us. CT of the thorax will be able to help us identify small volume metastasis, and CT or ultrasound of the whole abdomen will be done if there is presence of lung metastasis to be able to determine if there are other organs that are involved. MRI for CNS metastasis, vaginal and parametrial lesions. Again, what to do? Management should be based on clinical and histologic diagnosis. Again, for low risk, what's the score of low risk? Less than or equal to 6. So if the FIGO prognostic score is low risk, then we give methotrexate or actinomycin D. While for high risk, we should give a combination chemotherapeutic drug, the EMACO. While for PSTT or ETT, since these entities are relatively chemoresistant, then we do surgery. Surgery is the cornerstone for treatment. Again, in a third year level, at least be familiar with chemotherapeutic drugs. And if you like to read further, we have doses for this in the book. Although these are relatively chemoresistant and lacking support, there are still some who manage it with chemotherapeutic drugs. So this is what I'm saying earlier. These are the doses, the course of the drug regimen that we give for combination chemotherapy. EMACO, etoposide, methotrexate, actinomycin D, EMACO, cyclophosphamide, and vincristine or oncovin. That's why vincristine is O, because it's oncovin. Now, surveillance post-GTN. Again, very important recognition. RC is chemotherapy, and the S is surveillance. So for the surveillance sensitive test to determine the beta HCG for stage 1 to 3, monthly for a year, stage 4, monthly for 2 years. So basically, these are the information that you need for gestational trophoblastic diseases. If there are questions, I'll meet you in class. Thank you very much. I hope this will help, especially with the current context that not all are given the good internet connection after Odette. Please stay safe, everyone, and good day.